Welcome, everyone. It's nice to see you today. I am just so pleased that many of you have arrived without RSVPing, which is, it's not ideal from the standpoint of having enough plates and food for everyone, but it's fantastic that people have made this a habit, and we are a growing Right Care family, people coming together month after month after month. We're now at 3.75 years in this location, working on reducing heart attacks, strokes, and diabetic complications. And we have all of the major health systems in the room, very senior medical directors, very senior patient advocates, wonderful biotech and pharma support with us, our academic partners, and it really is what I call a we thing. And each of you have so much to bring. None of us individually can solve this problem. And I just appreciate all the passion that you bring coming into this room month after month, just to reduce what is, in Sacramento, a much worse problem with heart attacks and strokes than the rest of the state. So our great joint goal is to really drive down the rate of these preventable events through systematically deploying the knowledge that we have to prevent these devastating heart attacks, strokes, and diabetic complications. And I want you to think of this group as your support group, because everybody in this room is here because they care about making patients and families better off, getting better care. I was talking with one of our senior medical directors just prior to this and hearing about how really difficult it is to be in that position of saying, even though they have really improved their care, getting hammered, why haven't you done better? Why are your costs so high? And yet the health system is quite fragmented. We together can help reduce that cacophony and get some really important things done. We know that we have in our first community that we started in San Diego with the National Institutes of Health grant in 2011, where that community, by systematically deploying the interventions on the Right Care Triangle, the evidence-based patient activation and engagement, use of proven medication protocols, use of clinical pharmacists on the care team, intensive outpatient care, really getting everybody to work at the top of their license, team-based care, web-supported. That works. And we're going to have a paper published by Professor Susan Ivey and Professor Brent Fulton that was requested by a health economist working with us from UC San Diego, Dr. Michael Pollack, Carla's husband-to-be. He said, look, I think we've really made a difference here, meeting month after month after month. This was at our summit now 15 months ago. It takes a long time to get a health economist to plow through intense amounts of data. But what happened was the Office of Statewide Health Planning and Development Data that Brent Fulton and Susan Ivey have been plowing through now with the help of Amanda Liu and some of our other UC Berkeley and other UC faculty, and even RAND faculty help in thinking through the analysis. It looks like acute myocardial infarction hospitalizations have fallen by just under 20%, which is really phenomenal since 2011 to 2014. and that is much faster than the state trend. So the question is, what's it going to take to get that done in Sacramento, which is a much higher need community, frankly. We don't have an NIH grant. So we need to think of other ways to deploy the important interventions that are going to save those lives. And frankly, it showed that it would save, if we had done that well statewide, it would have saved approximately $500 million. That's real money. So it's not just the patient and family devastation that will be avoided. It's also physicians, pharmacists, nurses, quality improvement experts feeling better about what they're doing in their work and saving money at the same time. So we can save lives, save money, and but we can only do it if we do it together. So we have a very, we have some really wonderful guests with us today. Chet Hewitt, who has been the longtime sponsor of having us here at the Sierra Health Foundation. Chet Hewitt, the president of this foundation, threw his back out this weekend, so he will not be with us, but he will join us again soon. He is very passionate about this work in part because of his own family experience, and I think many of us bring that. And for those of you who are listening to the webinar from our Los Angeles University of Best Practices on Friday, what we did there, and maybe we can do that in a future University Best Practices, give everybody some time to think about it, is as we went around and introduced ourselves, several people talked about what makes them so passionate about this work. It's not just professional. Given that cardiovascular disease is the #1 killer, most of us have experiences in our own family. Most of you know that my mother died suddenly of a stroke when I was 15 years old. Talk about a life-changing event. And yet, that's not why I'm doing this work. It is very motivational, but I didn't start this project because of her. It's all of our families. And I can see in the data, and you can see in the data, that an immense number of patients who are diagnosed with heart disease, hypertension, and diabetes, or one of those conditions, are in grave danger. If we are not controlling their blood pressure, their lipids, and their blood sugars, then we are not managing their care, and they are at risk for walking over a clinical cliff of death and disability, which is completely unnecessary. So we have the power in this room to change that trajectory for the patients of Sacramento here, and that has echo effects across California. So our first speaker today, Mary Watanabe from the Department of Managed Healthcare, which is the mothership of the Right Care Initiative. Mary brings with her a passion for patients unlike any I have seen at the Department of Managed Healthcare. She's a very innovative thinker who has accomplished a lot in health policy in the state. And she's going to talk with us today about how the California Department of Managed Healthcare, which is the regulatory entity for health plans and their contracting medical groups, how our health center can help the physicians of California to resolve problems as well as the patients, to make sure that patients are getting the care that they need. So with that, Mary Watanabe, please join us.
Good afternoon. So it's my pleasure to be here with you. Part of my job as the Deputy Director of Health Policy and Stakeholder Relations is to promote the DMHC, and particularly our health center. I came from Covered California, where I spent 2 years bringing up our outreach and enrollment assistance programs. I talk a lot to community organizations. One of the challenges I have is community organizations don't always have access to people who are struggling to access and navigate the healthcare system. And so as we look to educate people about the DMHC, in particular our health center, Hattie and I have talked a lot about why you all are a prime audience for me to come talk to. Part of it is you share our passion for helping consumers and the diverse consumers we have in the state. But you all also probably have access to people who need health care, may have challenges, or you know someone that does. So I'm going to talk a little bit briefly just about what we do here. So the mission of the Department of Managed Healthcare is to protect consumer health care rights and ensure a stable health care delivery system. And that really translates into everything we do. The department has had 4 mergers before us that we've had to make a decision on. We've approved 2. We have 4 that are under review. One of the things that people ask me all the time is, what is the department looking for? And I will tell you at the foundation of what we're looking at is this. We're really looking at the impact to consumers and what does this mean for the healthcare system. Let me make sure I go the right way here. So in case you did not know, you may have known Hattie for years and you know she's affiliated with the DMHC, but I want to make sure you understand who we are and what we do. We are the largest regulator in the state. The California Department of Insurance is the other regulator, but we regulate 122 plans. That's 72 full-service plans, 50 specialized plans, which include dental and vision. It's more than just the HMOs in California. We have many PPOs and EPOs, dental and vision plans, as I said. A lot of times people will think, oh, well, it's just maybe Medi-Cal or it's just individual coverage, but it's also a large group, it's a small group. It is most of the Medi-Cal managed care plans in the state. It is the majority of covered California's plans, individual, and it really runs the gamut. Our authority comes from the Knox-Keene Healthcare Service Plan Act. We have 25 million consumers in the plans we regulate. So one of the things that I'm often asked is, well, who don't you regulate? And I always tell them, like, let's not worry about that. There's 25 million people in the plans we do regulate. So odds are most consumers that you're working with are in the plans we regulate. If they're not and you call us, we'll get them where they need to go. We've had significant growth at the DMHC. You see here just over the last 5 years with the implementation of the Affordable Care Act in particular. Our staffing levels have gone up, our budgets have gone up, and if you look at the consumers that we're helping, that is going up by 50 to 60% a year. Just to give you some sense of the change in the marketplace for the Department of Managed Healthcare, in 2007, about 67% of the plans we regulated were commercial. You'll see in 2015, it is equally split between government and commercial products. We're actually expecting probably in the next year or 2 that we will have more government plans than commercial. So who don't we regulate? Again, any plan that's regulated by the Department of Insurance. Medicare coverage, we license Medicare plans. We do some financial review, but we don't regulate them in terms of like some of the consumer protections. Fee-for-service, we also don't regulate the county organized health systems for Medicare, and then obviously the ERISA self-insured plans, and any private health benefit exchanges as well. So quickly, I want to talk about some of our key functions of what the department does, because this is going to be very relevant to when we talk about how you can leverage our health center to drive policy and legislative changes. But we review the plan documents, evidence of coverage, booklets, letters, notices. If anybody has been helping consumers over the last 3 years, notices has become a big issue. Covered California Medi-Cal enrollees are getting a lot of notices. They're often very confusing. So part of our role is to make sure that they are following the law on those notices. We ensure financial stability. We review a lot of the financial documents for the plans. We took a plan under conservatorship last year because of financial concerns. We review proposed premium increases. In 2014 alone, we saved consumers $41 million in unreasonable rate increases. It's over $100 million since 2011. We don't have the authority to deny premium increases, but we do review them. We'll talk to the plans when we find them unreasonable. Every 3 years, we do what's called a medical survey. So it's essentially an audit. We go out and review the plan, their compliance with the law. We can do non-routine surveys. We did that with Anthem Blue Cross and Blue Shield for provider directory issues. Provider directories are a hot topic right now. At the end, I'll kind of give you a little preview of some of the other things the department's working on that includes provider directories. And then we take enforcement action. People often ask me, does the department have any teeth? Who's got the hammer? It's DMHC. We can take enforcement actions, but I think more important than those fines and penalties is their corrective action plans. Our ultimate goal is to bring the plans into alignment with the law when we find a deficiency. And so what I want to focus on is our DMHC Help Center. You see the website, our phone number at the bottom. When I travel around and talk about what we do, I hear all the time, you're the best kept secret in the state. We don't want to be the best kept secret in the state. It's such an important resource for consumers. For those of you that have helped anybody that's enrolled in coverage, the 5+ million people that have accessed and enrolled in insurance in the last few years, it is very complicated. They don't know where to go when they get told no, or this is denied, or it's going to cost you money. Some of them throw up their hands and give up, and they're very confused. The DMHC has a help center. We're the place you can call to get help. We have information on our website. Services are fast, free, and confidential. I'm going to talk a little bit about our complaint process as well as our independent medical review, or IMR process. But the IMR process in particular is when a plan denies, delays, or modifies a care or treatment, which I think falls under a lot of what you all have been talking about in these meetings. A consumer can file an IMR with the department. We currently have an overturn rate of about 60%. So that means the consumer has more than a 50-50 chance of having a service covered when the plan has denied it. So part of what I think is very important is we talk about health literacy and an increasing consumer understanding of how to use the healthcare system. The grievance process of the plan is really the first step. And it's interesting to me as I talk to providers, to medical groups, to consumer groups, a lot of people don't know what to do when someone says no or complain. One of the things I talk about a lot, before I got into healthcare, I worked in retail. And I had a man throw a TV at me one time because it broke. It was 15 years old and it was my fault it broke. But I used to have people jump up and down at the front counter. They were angry their appliance or their TV or their Walkman, for anybody that remembers a Walkman, broke. But it's interesting that when it comes to their health care, people hear that's not covered, or they get a bill and they go, okay, the person in the white coat must be right. And they don't take the next step. So the next step is to file a grievance with the plan. Plans are required to resolve enrollee complaints within 30 days. If there's an immediate threat to their health, or the request is denied as experimental or investigational, they can come right to DMHC. We often will have people come right to us anyways, and if they haven't exhausted the plan's grievance process, and they should, we will send those complaints and initiate it on their behalf. And then if the plan doesn't come back with a resolution, or if they're not happy with the plan's decision, and they just say, I still think this should be covered, that's where they can come to the DMHC and file an independent medical review. It's an objective review by a third party. It's a clinical review. You have to apply for the independent medical review within 6 months of the plan's last written decision. We'll review it and decide if it qualifies for an expedited review. I think a lot of the people that you're working with may qualify for an expedited review. This may be a situation where their health is at risk, and it could be very serious if the person doesn't get this treatment.
Could you, I'm sorry to interrupt there,
Sure.
but could you talk about what paperwork is required and the importance of the written document?
Yes, so let me get through complaints, and then we'll talk about performance and best practices. So if it's a non-urgent issue, which I would say probably the majority of our IMRs fall into, we'll decide those within 30 days. So there's another category. If it doesn't meet that denial of medical necessity or experimental or investigational, it's a complaint. So we have timely access standards. They're on our website, they're in the law, and I will tell you the word month is not in any of them. You may hear about people waiting months to get an appointment. If their health is not at risk and there's a lack of providers, there's some situations where that makes sense. But in most cases, you should be able to get an appointment within 15 days. So one of the things people will come to us is say, I just called my doctor and they're saying it's going to be 3 months. The plan says I have to wait 3 months and I'm in a lot of pain. We'll work with the plans, and that's considered a complaint. Also claims, billing issues. Sometimes this is where someone has already gone to the doctor and now they're getting billed for something they don't think they should. Access to translation and interpreter services, or just complaints about a doctor, or help accessing continuity of care. We're seeing a lot of shifts in the marketplace right now, and a lot of contracting disputes with consolidations. And so sometimes what will happen is a consumer will need help getting continuity of care to stay with the provider that they've been seeing. So here's where let's talk about the IMR and complaint form. Yes.
So in terms of, also, can a provider complain representing a patient?
Yes. So
for example,
yes.
Let's say there's a formulary, and the formulary, there's a medication that the provider believes fits the patient better, and of course the patient doesn't know and doesn't have experience. So the provider may sometimes act on behalf of the patient, and is that within the realm of what is expected or supported by the DMAC?
Yes, I'm so glad you asked, because that's the big question that I think this audience needs to hear. The IMR complaint form is 2 pages, and there's 2 more pages for a total of 4. It's called an authorized assistant form. So if you are a provider and you go on our website, you're going to see a whole section that says provider complaint unit. Just know as a provider that only applies to you if you have a billing dispute with your plan. If you are helping your patient, it is the IMR complaint form. So there's a couple things that you need to keep in mind. We have to have the patient or the person who has the authority to sign on behalf of the patient, we have to have their signature authorizing us to get their medical records from the plan. And if they want you to help them, they have to sign authorizing you to be the authorized assistant. Everything else you could help them fill out. And I think that this is really important, particularly if you are dealing with someone with a chronic condition. I work a lot with our cancer organizations, people with brain injuries, and these are not families that are in a position to fill out one more form that's part of a state bureaucracy. And you will hear that from them. They will say, please don't ask me to fill out one more form. What you need to tell them is I need 2 signatures. I need you to sign here, giving us permission, the Department of Managed Health Care permission to access your medical records, and a second signature authorizing me or someone in your office to assist you filling out this form. There's a couple other things that you can do. We have an online form in English and Spanish. There's an electronic attestation that the person will do. It's the fastest way to get this to us. This is really bare minimum information. And what I will tell you is, this is not like what you may have experienced with other government forms. If you don't check a box or fill something in, we're not going to send it back to you. We will send it back to you if you, as the provider, signs the form. We get a lot of those. I'm working with a group right now where they're sending me 40 to 50 of these a week because we've got a particular issue we're struggling with. And the provider signed all of them. We can't do anything with that. We'll send it back. So have the patient sign. We have some situations where they have a power of attorney. You just need the power of attorney form, and whoever's authorized to sign can sign. Sign to be the authorized assister. The other thing is, if you are an out-of-network provider, one of our biggest challenges is getting medical records. So one thing that you can do to expedite this process is if you're out of network, send us medical records. If you're an in-network provider, when we send this to the plan will get those medical records from their contracted providers. You also can include a physician certification of immediate threat to your health. So as the physician, if you are saying this person has got to get this treatment, or there is a risk if this person is discharged right now, having that physician certification can really help to expedite the process. We have nurses that will evaluate expedited requests, but that can really help. I'm trying to think what else. We do have these forms on our website right now. We've recently combined the forms, so there's just one. It's translated into the threshold language, and I think we've got about 12 other languages. How many providers do we have in the room? Got a few. Okay. So I see your hand. I'll get you in just a second. One of the things that I've worked with some of our groups on is in the physician offices, depending on who is helping with this, and maybe your care coordinators, your member services, they are printing out the forms and they're having those ready so that when they're helping someone and they're calling for a prior auth, they're getting a denial, they're having them fill out those forms. One of the things I'll hear sometimes is people are, we're going through this authorization and grievance process for months. You shouldn't be going through that for months, right? 30 days, and then you can come to the department. So let me just see what else I have here. So this is our website that has our online form. You'll see kind of towards the middle there, English, Spanish, that's where the online form is, and then we have the other forms as well. You got a hand? Yeah, go ahead.
There was the one question about drug formularies, which my understanding is they can be included on these complaints. The other thing I run into a lot with many of our clients is the mythical mental health provider. They have this list of 50 or 60 people, and none of them are taking new patients. Is that something that can, to me, it's recurrent behavior. The patient, it's just this once for them. Is that something that can be addressed?
Could you elaborate a little bit more, Dr. Renner?
Sure. HMO plans in particular that we work with, and some of the PPOs, when you have a patient who's depressed or is having an acute sort of reaction and needs to see a mental health provider, it's very difficult to find them. We made some special relationships with our ACO in San Francisco and a couple other places, but that's not where I practice. So when my folks need somebody, it's very difficult to get them to be able to make that next step. And there's a wall between us and the mental health side, so we can't just get the list of the mental health providers. The patient needs to get it. So we have this awkward thing where the patient looks it up on the internet, prints out all the providers within their 15-mile area, comes back to my office, and we get to check and see if I know any of them. If I do, I can give them a direct call, or the patient's just stuck with the list, going through the list.
Yeah, so there's a little bit of a caveat there. Are you talking Medi-Cal?
No.
Okay, so Medi-Cal is kind of the only exception because a lot of times these more severe cases are carved out to the county and we don't have the regulatory authority. That falls under Department of Healthcare Services. But in every other case, if it's a plan we regulate, what we will do is we will work with the plan and we'll say we have one of your patients, we need to find them a provider who will see them, and depending on if it's urgent, with the timely access standards, there are cases where someone may be referred to a specialist, for example, and there's not an immediate threat to their health if they don't get in within 15 days, for example. And that's where it may be appropriate for them to wait longer. I think in many of the cases like what you're describing, part of what we'll work with the health plans on is they may need to find an out-of-network provider that can see this person at the in-network rate. So the cost sharing would be the same as in-network. So again, there's a lot that the department does to review network adequacy. I will tell you, we have a whole mental health work group right now, so if anybody's interested in that, let me know. And part of it is to really kind of work through how this works between providers and plans. We've had some really good discussions and made some connections between providers and plans. So they're just picking up the phone going, I am just struggling in my county. We don't have providers. Can you help me? But that is absolutely something that the department can help with. What I would suggest is if you've already tried working with the plan, they've given you the list, you can't find anybody, fill out the IMR complaint form. You could always call us too. It's one of those things where as the regulator, we will usually just pick up the phone and see if we can resolve it over the phone. Other questions? So I want to talk just briefly while I have a chance, because I know this group has talked about some of these experimental investigational procedures as it relates to the work you're doing. And one of the things that I like to emphasize is why is it so important for you to see IMRs and complaints? Even when you say, well, I have someone at the plan I call all the time. Part of what comes into our health center informs all of the other work that we do. It allows us to monitor trends. It may really highlight for us that in this county in rural Northern California, we've got an access issue. Or we seem to have a problem with a certain type of specialist in this particular area. We have found some of our claims payment issues have come out of issues that we're seeing come in at the health center. So it really informs all of the other work that we do. It allows us to make sure we're doing our job of monitoring the health plan's compliance with the law. The other thing that will happen is it starts to drive policy changes. When we see, as I mentioned, I have this particular case where I'm getting 40 to 50 IMRs for a particular denial of a certain treatment. There's debate about whether or not this particular treatment should still be experimental or investigational. part of what happens is the plans have to pay when we go to IMR. So there is a kind of a built-in incentive for everybody to look when we get a couple hundred IMRs over a 3-month period for a particular treatment. We all may need to